Welcome to an hour of HealthMade Radio. HealthMade is a community for natural health seekers who educate people about common health conditions and share extensive research on the most effective natural health treatments and promote legislation that protects our health freedoms. Our core concept belief is in the innate intelligence and healing power of the body, and if properly supported spiritually, emotionally, and nutritionally, it can find its way back to health. HealthMade Radio will bring information from integrative health experts throughout the world. Check us out at healthmade.co. Health is what you make it. I'm Dr. Michael Karlfeldt, and I will be your host. Today's guest is Dr. Robert Kushner. Dr. Robert Kushner has a long, distinguished career as one of the most highly respected weight management experts in the world. He is medical director of the Center for Lifestyle Medicine at Northwestern Medicine in Chicago, professor of medicine and medical education, Northwestern University Feinberg School of Medicine, past president of the Obesity Society and a founder of the American Board of Obesity Medicine that certifies physicians in the care of patients with obesity. Board certified in internal medicine and nutrition, Dr. Kushner is a passionate clinician, educator, researcher, and advocate in helping to improve the lives of those affected by overweight and obesity. A noted national and international speaker, Dr. Kushner teaches healthcare professionals about both the science and art of healing individuals lose weight, keep it off, and embrace the healthier habits that fit their life. Dr. Kushner, it's truly a pleasure to have you on the show today.
Dr. Michael, it's a pleasure to be here, and thank you for the kind introduction.
Well, thanks. So I am obesity. Obviously, is something that we as Americans we don't do very well with. I think we struggle being one of the top nations in the world when it comes to being overweight. So if you would give kind of an overview of where we're at and what direction we're going with that.
Sure. Just to put it in context, the latest statistics for at least American adults is 42% of us struggle with their weight and have a diagnosis of obesity. And if you add overweight and obesity combined, now you're talking about 3 out of every 4 adults. For children and adolescents, it's nearly 20%, just short of 20% that have obesity. So this is we call it an epidemic. It really is a serious problem. We know that obesity as a disease is a contributing factor to the most significant disabilities that we see here, such as diabetes, heart disease, sleep apnea, arthritis, and some forms of cancer. So I often call it the last condition that we just haven't quite tackled. You know, we're doing a pretty good job going after cardiovascular disease with medications and interventions, and we're very active in diabetes and cancer. But when it comes to obesity, it's kind of left behind, and we need to focus more on helping Americans and people around the world to live a healthier life and manage their weight.
And where do you see the trend going? I mean, do you feel that because obviously there are a lot of programs out there, do this and lose weight. You have ketogenic, you have the zone diet, there's so many different diets out there. So you would think that the majority of Americans would have the tools and how to tackle this issue. Do you feel that we are benefiting from that?
It's a challenge, to say the least. I think it's very important to point out to all your listeners that we think of obesity as a chronic relapsing disease, just like diabetes. And to get diabetes or obesity, we have a genetic predisposition to have it. So, for example, if people in your family struggle with their weight, your grandmother, your sister, chances are you have a genetic predisposition to putting on weight. And then we need the environmental exposure to bring it forward. So if you have a vulnerability to be overweight, and then you are exposed to high-calorie foods, ultra-processed foods, not getting enough physical activity, or taking a medication that causes weight gain, or long commute time, more sedentary activity because we're working at home and we're sitting in front of a computer, all of that will lead to weight gain. And the way our body is engineered is once we put weight on, it's very hard to take it off. we think of it almost like a ratchet, a machine, which is can have a ratchet element where when it clicks forward, it doesn't go back and it just clicks forward. That's often the problem with folks who live with obesity is you put weight on, you may try a diet, but then it ratchets forward. You'll end up weighing more than when you started. It's kind of a natural life history of obesity. It's a challenge to reduce your calories and be more physical activity in America because basically physical activity has been almost engineered out of certainly a lot of urban areas. And food can be found anywhere, and the cheaper the food, the less healthy it is. So the stakes are stacked up against us to live a healthy life.
So I'm curious. I just want to kind of get a little clarification. So you're saying that once you start to gain weight, it is hard to actually to lose it. I mean, it's kind of like you're in that process already. So why is that? What's the mechanism for that?
Yeah, I think that's the least appreciated and understood problem or the problem of obesity that individuals don't quite get. They think it's a problem of willpower and why can't you eat healthy and why can't you move your body around? And once you keep your weight off, why can't you keep it off? And it's because of the way that we are biochemically or biologically engineered. And it goes back to our ancestors, to millennia. When our species was being created and evolved, we used to have things like famine and starvation. And of course, we still see it today, but that was very common, hundreds of thousands of years ago. So the body developed these biological mechanisms to survive famine and starvation. So when food wasn't around very much, mechanisms were put in place to down adapt. In other words, burn less calories, be more efficient so we can survive long periods of time without eating. And then when food was available again, we would rebound and gain more weight. Now, the way that if you fast forward to modern time, we're not really exposed to famine and starvation anymore, but we are exposed to food all the time. So our weight is going up and up and up. Our brain kind of starts to adapt to where our weight is. And if you start 20, 30, or 40 pounds above a healthy body weight, your brain thinks, well, this is the weight we ought to be at. So if you try to go on a diet, which the brain thinks you're starving or there's a famine, it will put in adaptive mechanisms to halt the weight gain. Even though you want to lose weight and you're on a diet, the biology of the body is putting the brakes on. It doesn't want you to lose any more weight. And that is why very commonly experienced when people go on a diet, they get hungry. And the longer they're on a diet, the hungrier they get. They get cravings. They're not full as much. And it's hard to fight hunger. So when you give into it and you start eating more, the weight bounces right back up to where it was. So the body conspires against us, unfortunately, and we're not built for modern times.
So isn't there because I know in the past, we talked about set point, which is what it seems like you're talking about, that each time you're gaining weight, you're establishing a different set point. Isn't there a way to lower that set point in any way?
Well, certainly we have many individuals who are overweight, who manage to be more physically active, build it in their day, exercise, follow a healthy, balanced, controlled diet, and are able to keep their weight off. So there are people who can experience success, but the vast majority of people will go on a diet and regain their weight. There are two interventions that we know can change this fat mass set point, which is what you're referring to, the way the brain kind of sets a certain amount of body fat that you should have. And both of them work internally in our body on a biological way. One is using medications, such as semaglutide and some of these other medications that are around, because it alters our set point on a biological basis in our hormones. The other is bariatric surgery. Now, both of those may sound extreme to a lot of your listeners, but when someone is struggling with their weight, has moderate to severe obesity, now has sleep apnea, diabetes, hypertension, that is when folks like myself, who are experts in obesity care, think about more aggressive treatments in addition to lifestyle. And we have a conversation with our patients about the role of medication, just like we do with diabetes, or bariatric surgery.
So looking at that at lifestyle, because I mean, from in the circles that I'm in, they say, well, 5% is genetics and then 95% is lifestyle. So, you want to make sure that, obviously your lifestyle is what you focus your energy on. And then you can turn on, turn off genes, depending on your lifestyle, your chemical exposure and stress factors and all these kind of things. So if from what you have seen, the people then that are focusing on lifestyle, I mean, how successful are they overall? I mean, is that a viable solution, or is it's just a piece of the puzzle?
Mm-hmm. Well, for Dr. Michael, from a population point of view, and I think of obesity as a population health problem, in addition to seeing patients in my clinic, which would be a clinical problem. But from a population health point of view, it has got to be lifestyle. We're not going to put everyone on medication. We're not going to subject everyone to surgery, right? That would be overwhelming and almost a ridiculous idea. So we have to focus on living a healthy life, getting ultra-processed foods reduced from our environment and exposure, being physically active on a daily basis, making sure we get adequate sleep, deal with our stress. All these factors affect health. And from a population point of view, I think we can reduce the body weight of Americans. So instead of 42% of American adults having obesity, and that's the current statistic, I think we can improve that. And it does work through different ways, such as turning on and off genes, increasing metabolism, building muscle, increasing energy expenditure, and so forth. But among those individuals who are suffering with clinically significant obesity, the ones that I see every day in my practice, who also have all these other comorbid conditions, the conditions associated with obesity, lifestyle alone is often insufficient to maintain a healthy body weight for the rest of their life, and often need more aggressive treatments.
Yeah. Well, let's take a quick break. You're listening to Health Made Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Robert Kushner. He is one of the leading weight management experts in the world. We'll be right back. Welcome back to Health Made Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Robert Kushner. He is a respected weight management expert and a medical director of Center for Lifestyle Medicine of Northwestern Medicine in Chicago. So, Dr. Kushner, you recently came out with a book, 6 Factors to Fit. And this book, it highlights a completely different way of addressing the obesity issue, rather than focusing on, eat this, cut out this, and focus on that. You focus on a completely different paradigm. Can you tell me a little bit about, why you wrote that and how you came up with that?
Mm-hmm. Sure, be happy to. So when we say someone is overweight or has excess body fat, the other medical term is obesity, we are now thinking that it's not obesity, but really obesities. And the best analogy I can think of is 50 years ago or more, we said cancer, like everyone had cancer and there was one type of cancer. Of course, we don't think that way at all, right? It's like, what kind of cancer? And each cancer has its own story, its own risk factor, its own recurrence rate. Treatments vary from one cancer to another. And we're thinking the same thing now about individuals who are living with obesity. It's not just one homogeneous group. Everyone comes in with their own personal story, their own challenges, what causes them to be overweight, how they think, their behavior, the psychology of that individual. So after years of seeing patients in my practice, it became very apparent to me that I needed to get to know my patients much better and much quicker in order to provide treatment for them that is customized and personalized to them. We call that, Dr. Michael, phenotyping, right? Everyone has their own way of presenting. Marketers call it segmentation, right? Knowing your audience. So I realized that years and years ago, and started to identify factors on a very individual basis that was very unique to the person, that was leading them to gain weight and having trouble keeping their weight off. So I did what's called factor analysis and identified 6 factors that were pretty common among the population of individuals that I saw. And that by taking a simple 27-item quiz that, by the way, anyone can take free on my website at drrobertkushner.com. They can go on and take the quiz online and find out what those personal factors are for them. So within minutes, I would know what is getting in the way of those individuals that cause them to gain weight and prevent the weight from coming off. And I gave those 6 factors common names that people would resonate with them very quickly. So one of them is called the convenient diner. So that's someone who struggles eating healthily on the go, has a lot of high saturated fat, ultra-processed food in their diet, don't have time to cook, and are eating in modern world. Another diet-related factor, I won't go through all 6, Dr. Michael, but just another one from on the diet side is called easily enticed eater. So this is someone who struggles with eating temptation, someone who has difficulty keeping food on the plate. In other words, they have to empty the plate completely. Someone who's eating out of stress or emotion or boredom. They're not really eating out of hunger. It's more of a psychological effect or the love of food or cravings for food. So those are 2 of the 6 factors, just to give you an example, that within minutes of taking the quiz, I know what they're made of, what's their phenotype, what their problem is, and I can immediately start giving them recommendations in a very patient-centered way to help them with their personal problem. So that's what the book is all about. As you said, it's called 6 Factors to Fit Weight Loss That Works for You. It's a self-guide for someone to understand what their issues are and to go chapter by chapter on what really resonates with them and what their particular problems are.
And I think that is a fascinating way of looking at obesity, because it's exactly what you're saying. We've looked at obesity and overweight as just you lump them all together, just like you're saying, cancer or other disease patterns, and now being able then to recognize that these are different drivers and there are different reasons, and so then you can look at obesity in a much clearer way and address it much more specific. So I think that's amazing. So you have these individuals, because a lot of people already know that I am eating things out of boredom, or I'm eating, and that's frequently. I have patients coming in saying that, I'm depressed, I eat, I'm happy, I eat, or I'm bored, I eat. So how, with people knowing that, what can they do to break that cycle? Because that's a hard one for people to break.
It is. And there's an old adage that says, if you can name it, you can tame it. So first knowing what are the factors or the patterns or the conditions that make it difficult for you to eat healthier. So we'll stay on that theme of diet. So knowing what the target is, in the case of my book, what factor you have, immediately focuses your attention on what you have to do. So what the book is all about, and what I, of course, do in my practice, is once we identify the pattern or the factor, we then turn to a set of evidence-based strategies that are tailored to tackle that particular factor. So let's stick with the one you brought up, someone who is what I would call a easily enticed eater. One is eating out of emotion. So the focus there would be first know what the emotion is, and we often use diaries. So some of it is, you have to roll up your sleeves and do work. It just doesn't happen like anything in life unless you're very talented. You have to really go at this by rolling up your sleeves and use strategies and tactics that are going to take care of that problem. So I often use a food mood diary with patients early on. So understanding what occurred prior to eating and writing it down and looking at it. I think we all have examples when you actually write things down, like a letter to yourself, or write down what you're thinking, it provides clarity and mindfulness of what's going on in the situation. That's one of the things we do. The other is, if you're enticed by food around you, get control of your microenvironment. So there's no mandate that you have to have cookies, cakes, and ice cream in your home. That's called your microenvironment. Instead, have healthy foods in your home. If stress is causing you to eat, then you really want to then look into other stress-reducing approaches or techniques instead of coping with eating. That could be a mind-body app. It could be mini meditation. It could be going for a walk. It could be exercising. Try to come up with an alternative to actually eating. And another one, which your listeners may not have ever heard, is called urge surfing. Urge surfing is if you get an interest in eating or a craving for a food, if you just surf that urge, like, okay, I know I have this craving, but I'm like a wave, I'm going to surf it. And I know over time that wave is going to dissipate. And the same thing happens with craving. If you just urge surf it, just wait a little bit and distract yourself, it's very common that craving goes away. So these are all tactics that are in the book and I use every day in my practice that people really don't know what to do. So by giving them a whole laundry list of activities and strategies to tackle it, over time they can surmount and come over that particular factor.
I love that urge surfing, because I know I'm actually thinking of women going through delivery, where you have that pain surge, and instead of then being afraid and clamping down and kind of holding the pain, you're just kind of riding through it. You're breathing through it. So it's almost like you would do the same then with a craving, that you would, instead of being afraid and thinking that, oh, here it comes again, I'm going to lose control, you're just kind of you're observing the craving or the urge, and you're just kind of riding that urge until the peak is done, and then you're going to get to a lull.
It's a great comparison, and you're 100% correct. I'll often ask patients, when you get a craving, what do you do? And they go, well, I look for food. I said, well, have you ever not looked for food? And they go, no, I haven't. I always look for food. And I go, well, you know what? I want you to do the experiment next time. And just to reiterate what I said, when you get the craving, I want you to observe it, acknowledge it like you're a newspaper report. Okay, that was interesting. And you become a little bit more separate from it. And say, now I'm going to go ahead and continue to what I'm doing, whether it's exercising or being on the phone or on the computer or doing something else. And most of the time it goes away. And I'm going to use one other analogy, and I use this all the time, because cravings are often a biological impulse. We often have a feeling we have to go to the bathroom, right? But, if you're in the middle of a meeting, you don't go to the bathroom, right? What you do is you acknowledge it. Okay, I know I have to go to the bathroom. When the meeting is over, I'll go to the bathroom. And I'll bet we all have experiences when the meeting is over, we forgot we had to go to the bathroom. In other words, it doesn't get worse and worse and worse like a crescendo. It's the body just signaling, just a little reminder, I have to go to the bathroom, go fine, acknowledge, to move on. Cravings are the same way. And very often, as time goes on, the craving's gone. It doesn't even come back. So you have to, and it's empowering, of course, once you get control of that. So that's one of many, many strategies one can use when they feel they're addicted to food or their cravings, or every time I get bored, I have to eat. The answer is you don't have to, but you have to use the right behavioral and cognitive strategies to get control of it.
And so patients or people can then go to your website, drrobertkushner.com, and they can take this 27 question quiz and then figure out which factor they are, and then they can get your book, and then they'll find the solutions or understand themselves a little bit more what that factor entails, and then also have solutions that they can incorporate in their daily life.
That is correct, and that's what I hope. If you sign up, there's also blogs and newsletters and all kinds of tips that are delivered to you free to really help you along your journey.
Wonderful. Well, let's take a quick break. You're listening to Health Made Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Robert Kushner. He is one of the world's leading expert in weight management. He's also the author of the book, 6 Factors to Fit. We'll be right back. Welcome back to Health Made Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Robert Kushner. He's the author of 6 Factors to Fit. He is a well-respected weight management expert. So you are also part of a trial in regards to a medication called semaglutide. So I wanted to kind of see, because I remember when people are dealing with fen-phen, and there's a lot of medications out there that's been helping people to lose weight. And you alluded earlier, you communicated earlier that obesity, is a disease that is managed rather than something that is curable. Almost sounds like, so it's actually something that you have to manage from what I'm hearing. Am I correct with that?
Yeah, that is the way we think about obesity, and that's been a paradigm shift, Dr. Michael, for the past years, decade or so. I think we all have our opinions about obesity or folks that are overweight. On one end is basically gluttony and sloth, which is more of a moral problem. People can't take care of themselves. To people in the middle, this is you're just irresponsible. You don't have enough willpower. And if you're only motivated and took better care of yourself, you wouldn't look the way you are. All the way to the other end, which is the way we currently think about obesity now, and that is a chronic relapsing disease with biological underpinnings and appetite and energy dysregulation. I throw a lot of words at you. But the more we understand about the biology of obesity, the more we realize that there are metabolic and physiologic changes that occur in someone who is gaining weight and having difficulty taking their weight off. I see patients every day who tell me, you know what, I have never felt full. From the longest time, from adolescence on, everyone else seems to stop eating at the dinner table, and I do because I'm supposed to. It's a social norm, but I really never feel full. Other people will say, I finished lunch and I'm already thinking about dinner. And I don't want to think about dinner, but these thoughts come in my mind, and I just love food, and it's very difficult to turn food down. I feel like I'm almost addicted to food. Now, these are things that people rarely want to attain in their life, right? They don't want to be overweight. They don't want to have all the medical problems associated with being overweight. So these are biological changes and psychological and cognitive changes people have that are driven by multiple genes and then manifested, of course, through our environment and how we live our life. So, Dr. Michael, that's the current thinking of many of the individuals, at least that I see in my practice, that suffer from obesity. Now, some people, let's take people who immigrate to the United States, who within the first several years of coming to the United States, they gain 20 to 30 pounds. That is a perfect example of how your environment, the environment in America, causes someone to gain 20 and 30 pounds because of the exposure of food. And it's hard for them to turn that around because the food is not changing in America. They have to fight or swim against the stream not to eat food that is engineered for high palatability and wanting to eat more and more of it. That's what ultra-processed foods are all about.
So if you would take that individual, kind of spinning it, obviously it's not genetic then, because they were in an environment in the past with the same genes, and they were doing well. They're moving here to the United States, they eat differently, and they have a different result. So it's environment and versus the genetics. So if they at that point would then shift their eating to what they were used to, would they still be able to go back to where they were, or do they now have a different set point, so to say, like we're talking? I mean, once they start that process, then it's hard to reverse it.
Dr. Mike, I don't know if we know enough who's who. We talked before about obesities, not just one obesity genotype or phenotype. It's actually multiple. So my guess is that, first of all, let me back up. Not everyone who immigrates to the United States gains weight, right? But it is commonly seen that individuals struggle to control their weight once they come to the United States. Now, maybe actually they had a genetic predisposition to be overweight, but when they lived in the other country, food was not available, and they were doing more labor-intensive activities. And now that they're exposed, their genetic predisposition may have caused them to gain weight. That's not everybody, but that may be some. So the plot thickens, however, and I'll give you an example of this. Let's take Hollywood movie stars who gain weight for different projects, right? Movies. They may gain 20 to 30 or more pounds for a role in a movie. After that role is over, they don't remain overweight the rest of their life. They're able to get back to the weight they were. And I think there's two things going on there. One is it may have not been predisposed to being overweight to begin with. Number two, it was a very short-lived weight gain. They gained weight over maybe a few months and then took it off. Third, they had the means of working very hard, probably with a personal trainer, to get their weight back off. So there's an example where you can gain weight and take it off. Other common example is pregnancy. Right, many women have they'll become pregnant and they'll get back to the pre-pregnancy weight. But as you probably know, Dr. Michael, not every woman who goes through pregnancy does get back to her pre-pregnancy weight. Right, they may leave on 10 or 20 post-gestational pounds and never get back to where they were. Now, how do you separate one woman from another? It's hard to do. It could be genetic predisposition. It could be postpartum depression. It could be a woman who is in the workplace who's now homebound. So there's multiple factors that lead to what weight you're going to end up being depending upon your life experience.
And that kind of goes back then to the point you're making earlier. People are thinking that it's just willpower and not recognizing how complex of an issue obesity or being overweight is, that there's so many factors at play that you can't just keep punishing yourself. You need to look at the whole picture and recognize that this is something that needs to be addressed, from a wider, from a wider angle.
100% correct. I think we all, almost everyone suffers probably from we call weight bias. That you're walking down the street and you see someone who is, let's say, 50, even 100 pounds overweight. I will bet you that most of your listeners, the first thing in their mind is, how can someone let themselves get to that weight? Look how short of breath that person is. Why is that person doing it to themselves? And then we have to catch ourselves because, a lot of people think that way. And we have to catch ourselves. And reiterating what you just said, we have to think, you know what? That person may be coming from a family where everyone's overweight, or maybe that person was 100 pounds heavier and had some intervention, and now they actually weigh less than they did a year ago and never saw that patient on the street. Maybe that person is working in a commercial program or with a doctor right now, but struggling to keep his or her weight off because of genetic underpinnings and dysregulation of energy and appetite and so forth. So we have to really catch ourselves when we look at someone else and give an opinion about what's going on with that patient. And everyone has their own story to tell. And again, to reiterate what I just said, there's a lot of biological factors that lead to why someone weighs what they weigh.
Great, and I'm excited. In the next segment, we're going to get into the semaglutide, the GLP-1. That you did a study that was published in New England Journal of Medicine. You're listening to Health Made Radio. I'm here with Dr. Robert Kushner. We'll be right back. Welcome back to Health Made Radio. I'm Dr. Michael Karlfeldt. I'm here with Dr. Robert Kushner. He's a international leading expert in weight management, and he's also the author of 6 Factors to Fit. And you also led the study that I mentioned was published in the New England Journal of Medicine in regards to a medication called semaglutide. And what drove you towards studying that substance, the GLP-1? Am I correct with that?
Right, that you are correct. So what semaglutide is a medication that's injected once a week in increasing doses. And semaglutide is a glucagon-like peptide 1 receptor agonist or a GLP-1 receptor agonist. What GLP-1 is a naturally occurring hormone that all of us have in our body that is responsible in part for making us feel full and reducing our appetite when we are eating. So if you think about sitting down for any meal, at first you're hungry, right? And then you start eating. But as the meal goes on, you're less and less hungry. You feel more content and full. And at some point you say, I'm content. I don't need any more food. I'm full. And that sense of fullness then lingers right until the next meal. So that's a normal physiologic feeling that all of us, right, can connect with, because that's how we live our life. And one of the hormones that causes us to feel full is called GLP-1. It's produced in the gut, our intestine. It circulates up in the brain. So what semaglutide is we take the GLP-1, we synthesize it, and increase the intensity of it, or the amount of it, and inject it once a week back into the body. And the best analogy to think about what I'm talking about is insulin. Right? Insulin is a naturally occurring hormone that we all have, but when people have diabetes, we have to give insulin back to the body at much, much higher doses, and that controls the blood sugar. So with obesity, again, it's a naturally occurring hormone. We give it back to the body at much higher doses, higher intensity, and makes people feel full. And it turns out that semaglutide, in the studies you mentioned, I'm proud to say, was actually voted one of the 10 top clinical research studies in 2021. In fact, I'm going next week to a award ceremony that happens to be in Chicago, where they're honoring the top 10 clinical research studies in 2021. And this study that we're talking about today is one of them. And the reason it was voted one of the top 10 clinical studies, one, it was well conducted. It was sponsored by a drug company called Novo Nordisk. It was a global study. And we took individuals who live with obesity or were overweight, randomized them for out to 68 weeks to a placebo, right, like a saline solution, or the drug semaglutide. And after 68 weeks, individuals who were getting the placebo, and they all got lifestyle management as well. After 68 weeks, people on the placebo lost 2.4% of their body weight. Now that's minimal. It's not zero, but it's a small amount of body weight. In contrast, people who were given the same lifestyle management but weekly injection of the drug lost on average 15% of their body weight, and 1/3 of the people in the study lost 20% or more of their body weight. To put that in perspective, 20% weight loss in 68 weeks is starting to approach what some people accomplish with bariatric surgery. So this is the most effective medication we have today, almost 1.5 to 2 times more effective than other drugs on the market in helping people who are suffering with obesity, particularly those that are accompanied by other medical problems.
So this is something that is available for a patient dealing with obesity right now, or is it something that it will come to the market?
The drug was approved by the FDA this past year, actually in June of 2021. The drug name is called Wegovy, so it's Wegovy by Novo Nordisk. Right now, there's a hold on the drug because of supply-demand issues, and we're all familiar with supply issues coming out of the pandemic, and they're having the same problem. But anyone can go to their doctor who is suffering from obesity, struggling to lose weight or keep their weight off, and talk to their healthcare provider about medication to help them augment a healthy lifestyle. And there's many medications out there. This is just the one we're talking about. It's called semaglutide. And Dr. Michael, let me just also put the drug in context. This drug has actually been out for quite some time at a lower dose for people with diabetes. The trade name for folks with diabetes is called Ozempic. So that's been out now for, 5 years or so. Wegovy is the same drug, but at a higher dose. And both of them are given by self-injection once a week, subcutaneously.
So is this something that, let's say people dealing with diabetes and they're on metformin, is this something that they would combine with that, or this would be in lieu of something like metformin?
They would combine it with metformin. And it brings up another point I want to make, Dr. Michael, and that is, I talked about the paradigm shift in obesity before, right, the biologic underpinning disease. There's another paradigm shift going on in medicine, and I call it diobesity. And that is, we are now starting to think of obesity and diabetes, when they occur in the same person, need to be tackled simultaneously. So it used to be you go to your doctor or your healthcare provider, you have diabetes, and the doctor would give you medication to bring your blood sugar down and actually almost ignore the fact that you are overweight. We don't think that way anymore. When you go to your doctor now with diabetes, and if you also are overweight or have obesity, that healthcare provider should be thinking of both problems at the same time, because if you lose weight, diabetes improves. And we now have drugs like semaglutide that we're talking about that tackle both issues. It not only helps bring body weight down because it affects appetite, but it also increases the insulin your body produces to bring the diabetes down. So this is actually it started off as a diabetes medication. It has now morphed into a diabetes obesity medication.
So and I've seen that issue many times, that patients coming in and they are on insulin and they're still dealing with very similar risk factors, even though their blood sugar is under control. So by bringing something like this in, you would then, like you mentioned, tackle these other risk factors, because you're addressing then the obesity that then bleeds into these other risk factors like cardiovascular, inflammation, and so forth.
Right, it's exactly right. Because when someone comes in who has obesity and diabetes, that person also may have other obesity-related conditions that tackling blood sugar alone are not going to control, such as hypertension, sleep apnea, urinary incontinence, arthritis of the weight-bearing joints, fatty liver disease, psoriasis. All these are obesity-related conditions. So if you don't also think of obesity in this individual and you just focus on getting blood sugar down, you're going to leave all these other medical problems untreated.
And is there a danger with this drug? Is there something that people should be concerned about? Because obviously when you think of drugs, you always think of adverse reactions and what are the long-term impacts on my liver, kidneys. Is there something like that people need to be concerned about?
Sure. They certainly need to have a thorough discussion with their healthcare provider, right? We don't just give drugs to people without, having a conversation. The most common side effects of the drug are gastrointestinal, things like nausea, diarrhea, constipation, heartburn, and sometimes vomiting. These are side effects that can be controlled, can be mitigated by slow escalation of the drug and changing your diet and so forth. There are some contraindications to the medication. They're actually all in the commercials that you may see on TV. Individuals have a very kind of rare type of thyroid cancer or endocrine syndrome that your healthcare provider would rule out. That would be a contraindication. These are called carcinoid tumors of the thyroid, pretty uncommon. Individuals may have an increased risk of gallstones, so that needs to be looked out for. A history of pancreatitis, you wouldn't use it. But the actual contraindications, Dr. Michael, are actually pretty few. Most of them are side effects that you work with the patient in order to hold their hand and get them through until they get to that top dose. And it takes 3 months or so to actually get to the top dose. You slowly increase the dose every month. And that's what reduces the side effects.
This is very exciting because I know patients, you mentioned the other intervention earlier in the interview, the bariatric surgery, and I've seen many patients, doing that, and then they have obviously complications, digestive complications from that because they have less of a surface area to be able to break down protein, deal with digestive issues from that, and then sometimes they just start gaining weight even after the bariatric surgery, even if it is, 5-10 years later, because they don't change their dietary habits anyway.
Yeah, I can't think of anything more frustrating for someone who has been living with obesity for decades and then finally decides to have surgery for their obesity, only to find they may regain weight. You can imagine how frustrating and disappointing that can be for an individual. Part of it, as you said, Dr. Michael, is the challenge some people have in following the dietary program that's required. But it also speaks to the fact for many individuals, we do not have a cure for obesity. That may be sobering news for individuals who are struggling with their weight. But if you can imagine, you have a surgical intervention for obesity, only to find out it's not the most common thing, but some individuals do regain their weight. And that really speaks perhaps to difficulty following the diet plan, but also probably speaks to the power, the biological gaining weight, even when there's a surgical intervention.
Yeah, and like you're talking, you have the biological signals and that can then, that are so strong. So even though you reduce the stomach size, the signals are so strong so that it kind of puts you in that risk factor again.
Correct.
Wonderful. Well, it's been such a pleasure to have you on the show today, Dr. Kushner, and thank you so much for tackling this. This is what I would call epidemic, and it's been an epidemic that's been going on for a long, long time. And I'm really glad that you're stepping up and tackling this head on. So thank you so much for being on the show today.
Okay, well, it's a pleasure. Thank you for having me.
That is it for today. You're listening to Health Made Radio. Remember, check us out at healthmade.co. Health is what you make it.